to hear a very interesting discussion with a wide range of panelists today on implementing patient-reported outcome measures to improve health system performance. My name's Jennifer Sumner. I'm a Senior Research Fellow at the NUS Centre for Research in Health Systems Performance. A couple of admin points just before we get started. Please add your questions to the Q&A box throughout the discussion. Even if we can't address them during today's discussion, we will come back to you offline. So please add your questions. And also, you can get CME points for attending this talk. So please add your MCR number to your name, and then we can make sure you get credit for attending this discussion. So to kick us off, I'm going to be handing over to Prof. Valderes, who's the Director of the Centre for Research in Health System Performance and Head of Department of Family Medicine. Prof, over to you.
Thanks very much for the presentation introduction, Jenny, and welcome you all to this policy dialogue. The Center for Research in Health Systems Performance places a huge interest and priority in understanding how patient-reported metrics can be used within health systems to provide the crucial loop, ensuring that systems are suitable for to the needs, to the preferences of patients, both in the form of their experiences but also their outcomes. And this is the policy dialogue today. Culminates the previous efforts with other previous policy dialogues, and the completion of a policy brief that is available to you all, and further details about it will be shared later. So I don't want to spend more time and take more of your time. I'm sure you're itching to hear from the panelists, which I would like to thank them very much for the effort and for their involvement. And I'm very much looking to a very productive dialogue. Thanks.
Fantastic. So our first presentation today is going to be by Professor Nicholas Goodwin. He's Director for Policy at the Centre for Research in Health System Performance, and he's going to be introducing to us what policy considerations need to be factored when thinking about PROMs implementation. Over to you.
Thank you, Jenny. It's lovely to be here. So I'm working at CRIHSP, and I seek to support the health policy analysis unit that we have. And one of our key pieces of work is to develop evidence reviews that lead to policy briefings and policy dialogues on important issues. So we've been working for the last 9 months on doing an evidence review around patient-reported outcome measures. The policy brief is now available. It's on our website, and a link will be provided to you as well. For those who are uninitiated in this, patient-reported outcomes are any aspect of a patient's self-reported health status, and patient-reported outcome measures are standardised questionnaires that are used to capture these assessments. And PROMs, as most of us know, are part of a much wider movement, both globally and in Singapore, towards value-based healthcare, and have the significant potential to improve health system performance. So as we go through the policy brief, I'd also like to thank the people behind that, so particularly at CRIHSP itself, with Rebecca Yaha and Ko Wee Ling, who did most of the work on the evidence review. Also to our colleagues at the NUHS Value Driven Office, including Jaga Pradeba, who's here online to present, and Sandra Nolte, also, who will be a panelist from Monash University, for being the authors on this. We thank you very much for putting this together. I always like to start with the key messages, and the key message is that this policy brief is arguing that a national approach, a coordinated approach for a PROMs program, should be developed. And the key messages, I guess, as we go through the policy brief are these. So at the patient level, we know that the use of PROMs can significantly enhance the quality of clinical decision-making. It can support people's capability to self-care and improve overall quality of care as well. And the strongest evidence happens at the patient level. But when we were looking through the evidence, we also saw that the deployment of PROMs can have an impact at the organizational and system level as well. So there is increasing evidence to suggest that PROMs can support performance monitoring and quality assurance and continuous quality improvement in particular to improve the value in the way that we provide care. But it can also help to drive value-based healthcare initiatives and support policymakers in making effective choices about the focus of their policy reforms. What we see is that PROMs are increasingly being used globally, but their application is most often and primarily restricted to maybe local initiatives, perhaps that are clinically led or by a particular team that's working with a particular population or maybe on a particular condition, rather than necessarily being embedded in a regional or national approach. Having said that, we do begin to see this shift towards the more statutory systemic use of PROMs. But generally speaking, when you look at the evidence, primarily restricted to these local initiatives, and the systematic implementation of PROMs we see have many challenges to them, such as resource constraints and limited stakeholder engagement that we'll get to in the presentation. Importantly, patient and public involvement, whilst essential for effective PROMs implementation, current levels of engagement are currently low. And if we're looking at effective implementation, the evidence suggests we need a structured approach to both the initiation and the scaling of PROMs that is needed, and that can be supported by engaging in both national and international efforts that can integrate data for benchmarking, facilitate implementation lessons, maybe even share costs and promote training and education. So those are the key takeaway messages from the report. Let's go into a little bit more detail before we pass on to the presentations from the three clusters. Let's first have a look at the growth of PROMs. Well, the international development of PROMs has its origins from the early 1980s, both in Europe and the USA, as we're collecting information from patients in order to provide more holistic care, specifically in understanding how we can maximize both their health and well-being and their physical functioning. And certainly in the last 2 decades, we've really seen a step change occurring in the use of standardized PROMs tools, PROMs that can be used in different clinical settings that promote higher value healthcare. And that's very much been accelerated and supported by some international initiatives, such as OECD's patient-reported indicator surveys or the Paris Initiative, and also the International Consortium for Health Outcome Measurement, or ICHARM, supported that. And we also see the growth of that happening in many different countries, certainly here in Singapore, with the shift towards appropriate and value-based care that regards PROMs as one of the foundational components of healthcare transformation. As of 2024, we see estimates of well over 100 different PROMs being used across 35 different conditions as a base estimate. This slide shows that from an OECD report in 2025 that looked at 38 different countries, and in the diagram you see some of those countries represented on the left-hand side, targeting quite a number of maybe 54 different programs, 50 different population groups. Many of them using key tools such as EQ5D, which is a generic tool to look at health-related quality of life that measures issues to do with pain and functionality and people's ability to have activities of daily living. And when you start to look at the use of these tools, this particular survey found that the majority of them were used directly for clinical quality improvement, maybe just over half of them for quality assurance. So the key message here is the increasing use of a whole range of different standardized tools to promote health system performance across a range of different, primarily high-income countries, although primarily focused in smaller scale, particular clinical settings. The value of PROMs or the impact of PROMs we looked at very closely, and both the policy briefing and the subsequent paper we're looking to produce will say more. But certainly at the patient level, we see a number of different advantages, quite clear evidence on advantages related to improving patient clinical communication, and the ability to use PROMs through shared decision-making between clinicians and patients in a way that allows them to understand their conditions and make effective choices, different behaviors, improves the quality of clinical decision-making, helps patients make certain choices, And as a result of that, we see improvements both in measurable quality of life, but also health outcomes. But increasingly at the organizational level, we also see the use of PROMs in benchmarking quality of care, driving higher performance healthcare, and also accountability performance. And increasingly at the system level, using this data to evaluate practices and policies and using it as a lever through routine collection of data to improve healthcare productivity. Within the document, we also had a look at key influences, the enablers and barriers to PROMs adoption, which we looked at a number of different levels, both at the clinical and service level, but also at the organizational and system level. And the diagram on the right, which I won't go through, but is there within the report, put this through the consolidated framework for implementation research to understand what the issues are at different parts of the system, whether it's the outer setting or the inner setting, or things that are happening at a sort of the implementation processes. But if I was to distill some of the arguments that were coming out for me, some of the key influences, both as barriers or as supporters of the process, are often the attitudes. It's the culture of value. It's the attitudes of the clinicians and the people involved in their perception of the relevance of PROMs that are really quite important here, and their understanding and clarity on the clinical responsibilities that they have, the ability of training and implementation support to enable them to understand what's required. And if that's backed up by program leadership that kind of mandates the approach and provides resources to integrate IT systems so that we're providing information in real time to make decision making, then we begin to move into an era where implementation is more effective. However, we see, remember the OECD report that I mentioned, it also suggested that only about 20% of the programs that it investigated had effective patient and public involvement of any particular approach. And yet we know that effective PROMs implementation requires meaningful patient involvement to strengthen patient-centered care, to drive trust with services, to improve the relevance and acceptability of the different measures we use, and particularly to help with that improved communication of patient preferences and needs with clinicians in order to be able to drive shared decision making, drive better care outcomes, and improve the relevance of what we collect to support patient care. However, the experience suggests that levels of patient engagement are low. Often the measures that we collect are misaligned to people's experiences or potentially less clinically relevant to them in their own situations and do not meet their holistic needs. And if we get into that situation, we often see low completion rates, poor data quality, issues with clinical engagement that become problematic. So the importance of patient and public engagement is just as important as clinical engagement as we start thinking through the selection of PROMs and PROMs use. So what we see here is that patient and public involvement should occur actively across the PROMs implementation journey, and that requires purposeful and skilled facilitation, as well as dedicated resources and so forth. So finally, when we come to the implementation of PROMs, which we looked at in the report, what we find is whilst we can get away with maybe a single clinician thinking through how it might collect PROMs data using a WhatsApp app in a small clinical setting as a pilot trial, if we're going to do this more effectively with greater impact, we need to integrate PROMs into routine care through a clear implementation strategy. And this requires coordinated stakeholder engagement. It implies changing workforce roles and skills. It needs new technological capabilities to share and transmit data, potentially to have dashboards of information for people to examine, to make logical choices. It involves change management process and cultural shifts, so it succeeds when there is some sort of structured approach available. Unfortunately, we do have some evidence within the literature that enables us to look at this, and I think this is included in a colleague's slides coming up as well. So here is some work developing a healthcare system implementation framework for PROMs developed by Ernst et al., which really is a maturity model. So what it is that we would need in order to move from, say, the first experimentation in PROMs on the left-hand column all the way through to system-wide adoption and vibrant ecosystem on the right-hand column. And it allows you to have a look at whether you can self-score yourself in terms of the scope or the metrics you use or the tools that you have or the cultural stakeholders and their engagement and the issues to do with governance and rewards and contracting to see to what extent you are scoring things that are implemented or things that are fully in place. And it allows you to self-reflect on the extent to which we're still in the sort of early adoption phase or whether we're actually moving to system-wide adoption and a more vibrant ecosystem. So there are tools that will help us in the implementation. So the final slide, and in all of our policy briefs, we look towards policy considerations or issues to address, and we come up with 4 of these. And these are the 4 questions we're going to come to our panelists later. So the first one is a question that's related as much to culture as anything else, which is how can national policies develop a culture of improvement in which healthcare professionals are incentivized to learn from and act on PROMs data? How do we get it embedded in the system? The second one is related to patient and community involvement through the whole process of PROMs design and development and implementation. How can that be best achieved? The third question is how can we invest in data infrastructures to realize the full potential of PROMs? And the fourth question is to what extent should we use it at this stage, not just for quality improvement processes, but actually quality assurance processes. So we're holding the system to account to the extent in which they're meeting effective PROMs outcomes. So with that, Jenny, I'm going to pass back to you. That's a flavour of what's in the report. And now we look forward, I think, to the presentations from the different clusters.
Thank you so much, Nick. Thanks for sharing some of the highlights from the recently published PROMs policy brief. If you are interested to learn more, the link has been shared in the chat, or you can reach out to any member of the team. Just another admin matter. I noticed some of the participants were raising their hands during that discussion. If I ask you just to hold on to those questions towards the end, we're going to have a sharing session from the 3 clusters now, and then we'll get into some Q&A towards the end. You can also put your questions in the Q&A box whenever you feel ready. So without further ado, I want to hand over to our first presenter, Ms. Huang, Assistant Manager from the Value-Based Care team at NHG. Thank you.
Thank you, Jenny. All right, so good afternoon, everyone. Thanks for joining us today at this policy dialogue. I'm really happy to be here today to share a bit more about what we are doing at NHG and also to learn a bit more about how our fellow colleagues are implementing PROMs. Now, when we talk about PROMs, we often talk about it as a tool for understanding our patients better. But if we want PROMs to improve healthcare systems and not just individual consultations, we need something more. We need a scalable ecosystem for collecting, governing, and using that data. So NHG Health has spent the past few years building towards that vision. And along the way, we learned 3 lessons that nobody told us at the start. And that's what I would like to share with you today. So to understand why we embarked on this journey, I think it's important to recognize that PROMs were not new to NHG. Clinicians across our institutions have been using it for many years. But the challenge here was that these efforts largely existed within individual teams and departments. And, different PROMs were being used, data was collected in different ways, and information was often stored outside of our electronic medical record system. And as a result, all these valuable PROMs data remain fragmented, making it really difficult to compare outcomes, use the information longitudinally, or to learn from it at a system level. And that's where we saw an opportunity to change that. So for today's sharing, rather than giving you a highlight reel of our PROMs journey, what I would like to do is to share 3 key lessons that we have learned from our experience. And hopefully that could give you some insights on what works and more importantly, what doesn't work. And then of course, if you would like to find out more, you're really welcome to connect with us after the session as well. Yep. So the first thing that nobody told us at the start was how much foundational work was needed before you can start building anything at all. When we first started out on PROMs, it was actually during a time where the entire nation was going through a migration to NGEMR. So that's our common EMR system. And as one of the first clusters to onboard Epic, the cluster's priority was really in transitioning to the new platform, right? Transferring all of our existing capabilities to Epic. And having started from scratch, None of the features that we use today, like our automatic questionnaire assignment workflows or the reports that we use to extract PROMs data, none of that was built yet. So PROMs was really, it was kind of like a foreign topic, which our technical builders simply had no time to talk about. We also quickly realized that every step forward required answering a question that has never been asked before, right? Like, who has the authority to clinically endorse a PROMs build? What licenses do we need to use the PROMs? Who's going to pay for them? And of course, critically, what happens if a patient flags an abnormal response? So these weren't questions that we could just Google, right? We sent out queries, we got no responses. We tried setting up structure like a PROM steering committee, and we were told to stand down after one meeting. We also invited clinicians to put up their requests, but everyone had different preferences for what PROMs they would like to use and how they would like to use them. And figuring all of this out, it took us close to 2 years, and these were 2 years that didn't show up on any dashboard or had any KPIs captured. But we pressed on. Whenever we hit a roadblock, we would pivot to tackle other things. And so in the close to 2 years of us pushing for cluster-wide implementation, we tackled the various elements that were needed to set up a sustainable system for PROMs implementation. I'll give you some examples over here. So first would be licenses, right? So this means getting the necessary permissions so that we can use the PROMs. And at the same time, we also took a future-proof kind of approach by including our fellow local clusters in the process. So that means that, for example, if NUHS, who is sharing the same, who is also using NGEMR, if they would like to use any of the PROMs that has already been built, they could do so without going back to the authors again. And this kind of really set the foundational work subsequently for accelerating the PROMs implementation nationally. It also required dealing with things like clinical governance, right? So that means assessing any risk in implementation and deciding as a group on how we will manage abnormal responses. One example that I can think of is the PHQ-9. So this is a questionnaire that asks about patients' depression symptoms. And there's a risk over there that, patients may report severe symptoms or have thoughts about self-harm. So we brought this discussion to our clinical board, where our institution's CMBs sat in, and we also brought it to our subject matter experts over at IMH. And after establishing some principles on how to approach these risks, we then work with the reps from our various participating institutions to iron out the details for translating this workflow into technical requirements. So that's another example of what we need to address. Another example would be finding out what are some of the features that are available in Epic for us to use. And actually, sometimes that also meant figuring things out together with our technical builders, because so many of the features that we asked for at the start were novel to them even at that point in time. So these are the many fields that we tackled as we waited for that opportunity to start building our PROMs digital collection workflows. And honestly, these 2 years were the reason why we were able to onboard a new PROM in a fraction of the time nowadays. So the key lesson that I wanted to share here is that PROMs implementation is governance design work just as much as it is clinical or technical work. It takes longer than anyone expects, but the initial investment is what makes scaling possible in the future. The second thing that no one tells you about is that the clinical landscape will shift beneath you, and your implementation has to shift with it. I'll give an example. So in 2022, that was when we first started, right? We gathered interest from our clinicians across the cluster, and the responses were encouraging. PROMs tools were selected, workflows were being harmonized. Then in 2024, when we reached the UAT phase for one of these PROMs, our clinician said, I don't want to use this anymore. So this is an example of where contexts have changed, clinical priorities have evolved. And what did we do? I mean, we had two options, right? Either to push through anyway, or to go back to the drawing board. We chose the latter. We sat back down with our clinicians, and we reselected a more relevant PROM for that condition. And this time, we also secured the HOD's endorsements upfront across all of the institutions. And we also applied this approach systematically. Having learned from this experience, we reevaluated the clinical relevance and the operational readiness for every remaining prompt that is on our list before we proceeded with it. It costed us some time, but it was the right thing to do. And the lesson to take away from here is that, context changes, but don't be afraid to course correct, even if it's late in the process. A prompt that nobody uses is worse than no prompt at all. Now, the third lesson that I would like to share is that patients need trusted messengers. So back then, when we were trying to drive up the response rates for our prompts, we tried two things that felt sensible at that time. We produced posters and brochures explaining the value of prompts, and we also ran an incentivized prompts self-reporting exercise with NTUC vouchers. But what happened was that we almost couldn't give away all of our vouchers. And participants who do participate for the voucher, they might not necessarily do so when there's a lack of such incentives in the future. The patient education materials fared no better. Patients would glance at the posters on a wall and then they would keep walking. And when we looked at the data, it's telling us the same thing. And what we realize here is that passive communication, be it financial incentives or printed materials, they're not enough to drive sustained behavior change. Patients need to hear about prompts from someone they trust. This could be their doctors, their nurses, pharmacists, allied health professionals, their care coordinators. Because when a clinician tells them, "This questionnaire helps me understand how you are doing between visits," that lands a lot differently compared to any brochure that we can produce. So what are we doing now? Now we are taking a more long-term view in patient education. We are still building public awareness collaterals, yes, but more importantly, we are also equipping our ground staff and our clinicians to better deliver a consistent and meaningful prompts messaging at the point of care. And so the lesson here is that you can't throw money at the problem and you can't incentivize your way to sustainable prompts adoption. You have to invest in your people just as much as your systems, because patients respond to messengers that they trust and not the materials that they are handed. Right, so those were the three key lessons that I wanted to share. And where does that leave us today? Well, over the past few years, we have moved from fragmented, largely localized prompts efforts to a more systematic approach in implementation. We now have an end-to-end implementation blueprint that covers everything from defining the clinical use case to securing licenses, technical builds, reporting and analytics, and change management. And with that, today we have 24 prompts that have been systematically scaled beyond individual teams and institutions into a cluster-wide implementation model. And all of that shares a common Epic infrastructure. An achievement here is not really the number of prompts per se, but rather having a repeatable system that allows us to scale prompts implementation in a sustainable and systematic way, such that we can generate insights that improve care beyond a single clinic or an institution. With this blueprint, we also managed to tap on more features in Epic to help with administering and analyzing the prompts data. So here are some of the examples that you see on the screen. And a benefit to having a shared platform is that once built, all the institutions who are using Epic can actually seamlessly hop on to using these features without having to build from scratch again. Here's also an example of what the patient journey looks like and how we are using Epic to make prompts reporting easier for the patients and also data analysis a bit more accessible for our clinicians. I'd also like to share an example of how exactly we're using the prompts data using the GINA assessment of asthma control. So this questionnaire asks patients about their asthma symptoms. So when analyzed using validated clinical tiering frameworks, GINA actually provided actionable insights into symptom severity across care settings. So, for example, it helped our clinicians identify patients who have well-controlled symptoms in the acute setting and thus have the potential to be discharged to primary care. And it was because of this, Gina was also selected as one of NHG's harmonized list of discharge criteria for asthma patients, and this is used across institutions. At the cohort level, it also showed us the distribution of patients across care settings based on their reported level of symptom control. And that allowed us to identify suitable patients for right siting. So for example, we can see that in the SOCs or the acute hospitals, there's a group of patients who are reporting well-controlled asthma symptoms. That's how we know these patients potentially could be right-sited to primary care for future management. So in many ways, this is really what the journey has been about, not just implementing questionnaires, but rather building systems and foundation that will allow PROMs data to be used meaningfully at both individual and system level. So to wrap up, if I could leave you with 3 key lessons, firstly would be to budget for invisible work. So the governance, alignment, and relationship building may not show up in a dashboard, but they're often the foundation that everything else rests on. Secondly, don't be afraid to rework things. Clinical priorities change, operational realities could change, and your implementation has to evolve with them. And last but not least is to invest in your people. Patients trust conversations more than comms materials, and sustainable adoption happens through trusted relationships. Yeah, so, we're still learning and there is still a long way to go. But if our experience has taught us anything, it is that, scaling PROMs isn't just about choosing the right tool. It's about building the ecosystem that will allow these measures to improve care, inform decisions, and ultimately strengthen the healthcare system. And I really hope some of the lessons that I've shared today could also help to make your own journey a little smoother than ours was. Thank you.
Thank you. That was a very insightful talk. Thanks for sharing about all the hard groundwork that goes into PROMs implementation and particularly how dynamic it is. It isn't a static process. It's always changing and you have to adapt. So really informative. Next up, we're going to be hearing from a colleague from NUH, Dr. Pradipa from the Value Driven Outcomes Office. Over to you.
Okay, thanks, Jenny, and thanks to the CRIHSP team for hosting this. Very much looking forward to sharing what we've been doing. So my name's Jagger. I am from the Value Driven Outcomes Office at NUHS, and I'm also helping to lead the PROVE program, which stands for Patient Reported Outcomes for Value and Experience. So I wanted to talk you through what our strategy has been looking like. For the past 10 years at NUHS, we've been driving value-based care. To take things back to first principles, value was defined by Professor Porter and Teesberg as value being the quality of patient outcomes relative to dollars spent. So whilst so far, for the past 10 years, quality has been primarily driven by how clinicians have been deciding what that quality looks like, with video input. At the end of the day, we're trying to identify what value looks like for patients. So we think patients should have a say in that. And that's really how we see PROMs. We see PROMs as a way to democratize the definition of value. By including the patient voice in the equation, we see PROMs as a way to do that and to do it in a standardized and robust way. As mentioned before, PROMs is not new. They are standardized patient questionnaires that have been around for decades. So even when we started at NUHS, just as Leslie had said with NHG, it was not new to us. So there had been many pockets of activity across the cluster, but these were largely independent, often research-driven, and there was no central view of what was being collected, how the data was being used, no sharing of learnings, and definitely no inclusion of going back to the value equation. So our aim wasn't to take ownership away from clinical teams. Rather, it was to create a common strategy, a governance architecture, and the infrastructure so that PROMs could move beyond isolated projects and become part of routine care in a more harmonized and scalable way. To lay the foundations for this work, we deliberately took a co-design approach. We wanted to actively engage our people on the ground all the way through to our senior leaders from the beginning. And the reason for this was quite simple. Culture eats strategy for breakfast. And having a strategy is great, but ensuring that everyone is on the same page is arguably more important. And end of the day, culture is a big part of how we've been driving value-based care at NUHS anyway. So we wanted to understand from our people what was working, what was not working, and actually what we could hope to achieve. The insights from this workshop were very consistent. They showed a very clear mandate to reduce the fragmentation, and in particular to ensure that things were integrated into existing workflows and that there should be clear feedback loops for insights as well. One of the other core underlying principles for the strategy is that PROMs needs to create value at multiple levels. So at the micro level, they needed to support conversations between patients and clinicians and improve individual care. At the meso level, they help us evaluate services and drive quality improvement. And at the macro level, particularly at the national level, they're there for benchmarking of outcomes data that helps drive resource allocation and value-based care. Our goal was therefore to ensure that we build the capability to realize value across all three levels, rather than just treating PROMs as simply another data collection exercise. The reason we invested in these processes through Proof is because it's really difficult to achieve that meso and macro level without a more coordinated approach. Fragmented projects can obviously help support individual care, but a system-wide learning is needed to drive improvement. And that's where the standardization and centralization comes in. So again, just as NHG had pointed out, a governance layer was really the opportunity that we saw. As a result of this, we set up the Proof program just about 6 months ago now. Our approach was essentially across 3 angles that we believe are super important for successful PROMs implementation. So that's people, process, and technology. By people, we mean the patients, the clinicians, the operational teams, essentially all the stakeholders that you need to drive education engagement, because really we saw this as a change management challenge. By process, we mean the harmonization and the standardization of workflows, timelines, governance. And by technology, we mean the digital infrastructure that enables PROMs collection, system integration, analytics, reporting to make the data actually useful. In terms of execution, we saw this as not just operationalizing with the right teams and workflows, but also ensuring that the feedback to the value equations was happening. And this was particularly by leveraging the existing VDO infrastructure. But the other point was also innovation and research. So we're quite blessed to be able to work in partnership with NUS, and this is where our collaboration with the CRIHSP Center comes in. This includes not just things like today with a policy briefing, but includes validating PROMs tools that were perhaps developed in other countries, but we need to validate in our local Singapore context, and even developing our own Singapore-specific tools where we feel others might fall short. But this idea of context and applying local and application to our local context was always going to be key in bridging implementation gaps. Since we started, actually one of the first insights has often been that there's a belief that with the right technology, you can get the results that you're after, that you get the right response rates, the right engagement, the right insights. But we actually found that tends not to be the case. Technology is definitely important, but it's an enabler of value. It's not the source of it. The more important question we found was, why are we collecting this data and what are we going to do with it? And because technology helps you scale, you therefore need to be careful about what you're scaling. And that's really one of the key messages that we're trying to drive to our clinical teams, particularly to make PROMs business as usual. The second angle is actually that we can treat this as an iterative loop. when we implement PROMs in a clinical area, it's often new to everyone. So we can start simply, even if it's just paper and pen. And this can quickly help answer operational questions like, can our patients understand the questions that we're asking them? Is it feasible in the current workflow? Does it capture what we hope it would? And where it falls short, we found that the more lower level that technology, the faster it is to iterate and change things. And we also found that actually when you analyze this data and feed it back to the clinical teams, even as early on as 1 or 2 months in, it's actually one of the best ways to motivate teams and again put everyone on the same page as to what the potential value PROMs can unlock. So just to finish off, we definitely feel that successful PROMs implementation particularly depends on people and process. We feel that teams need clear roles as to who is supporting patients in completing the PROMs, who's reviewing the data, who's discussing them during care. They also need well-designed workflows that specify when PROMs are collected, how results are reviewed, and what action should follow. Technology should enable these workflows to making completion easier, integration into clinical systems, and essentially scaling when it's ready. But without engaged clinicians and clear processes, even the best platforms risk becoming just another administrative task. Ultimately, we feel that this requires a whole of system effort. And that's why we really support discussions like this today with the policy briefings. They're important to help build a shared understanding, help build engagement across clinical, operational, leadership, and policy levels. Because ultimately, we feel that patients should have a say in how value is defined, and we do see PROMs as one of the best ways to enable that. Thank you.
Thank you. Fantastic talk. And thank you so much for highlighting the importance of change management. Without engaged stakeholders, even with the best infrastructure and technology, your progress will be limited. So fantastic. Okay, so this takes us on to our final presentation from Sing Health. Professor Fumbo, would you like to present?
Thanks very much, Jennifer. Can you hear me, please? Great. Hi. So good afternoon, everybody, and thanks very much for the opportunity to share what we're doing in Sing Health. I really appreciated the sharing from NHG and NUHS, and we share many similar pain points. I'm a rheumatologist and a health services researcher, and PROMs is actually one of my research focus areas. We've been working in this area for more than 20 years, so it's lovely to see the accelerated interest and hopefully national adoption for PROMs that's going to happen in the next few years, and really appreciate especially that policy document and this meeting. So I'm going to briefly share a little bit about our progress in Sing Health. And so as you can see here, we really wanted to embed PROMs in clinical care. And similar to our other fellow clusters, we've actually seen that PROMs implementation has been fragmented. And now we're trying to take a cluster-wide approach. We've been using PROMs, individual departments for more than 10 years. My department included, as a rheumatologist, patient-reported outcomes are a key part of our practice. We realized that we needed to actually lay a foundation. So some years ago, we put together a cluster governance system, digital platform, and now we're in the process of scaling and optimizing. So as of a couple of months ago, we have about 120 active PROMs projects involving 138 unique questionnaires across the cluster. It's interesting. We actually came across this very helpful framework that I think Prof. Goodwin mentioned earlier on, and we found this very helpful. So we've adopted this as the framework for implementing PROMs within Sing Health. I don't want to go through this in great detail, but I would just say that this has been very helpful for us to frame it. Right now, we're somewhere in between scaling and wider adoption. And of course, that varies across the measurement and utilization domains of this framework. We actually started off by sending all the institutions a structured survey based on this framework, and that allowed us to provide targeted support to help institutions with specific areas where they needed this help. So this has been very useful for us. Some of the challenges that we've identified to unlock full value of PROMs at scale are listed here. Now, I think these are really not a surprise. Silo implementation is a challenge. And so what NHG has done with Epic is really very nice. high questionnaire burden is something that we've encountered, especially with static questionnaires. And so we're thinking of using computerized adaptive testing to help address this. Clinical integration is something that is an issue, and we've heard about that as well. And of course, the big one that's coming up is epic migration. So we see this as both a challenge and an opportunity to really make PROMs clinical integration the default, and we're going to see what happens in 2027. So we have a work group which reports to Value-Based Council. Several of us co-chair it. So it's quite interesting that we have a value-based care lead, Wei Wei, who's doing operations, and myself as a researcher. And importantly, we actually have stakeholders from across all the institutions involved in this group. And so this is really the nexus for making decisions on implementing PROMs. We have taken a top-down and a bottom-up approach. Top-down because we recognize that there are strategic priority conditions that MOH has prioritized for PROMs implementation within the next 3 years. And so we want to definitely align with this. And we also do want to engage with a top-down approach from various institutions because they have priorities that for conditions they think are going to be important. There's also the bottom-up approach because ground feedback and interest is, I think, quite critical. We like to identify conditions already implemented and see whether we can scale these. And I think this combination we hope will be effective. We do this through centralized change management, providing a knowledge repository and cluster-wide scaling, and of course sharing best practices across what works where and when. So I'd like to share a couple of case studies to illustrate how we actually implemented this. So this is actually stroke, and we use the iChomp set for stroke. The unmet need was basically that post-stroke discharge care was varied with patients followed up at different institutions. And so we implemented a telecare service for ischemic stroke patients from April last year with the iChomp stroke set implementation integrated into the service. So as you can see here, 1 month post-discharge, patients are given the EQ5D5 level with a post-stroke checklist. Similarly, at 3 months, and we've actually enrolled about 482 patients over the last year, and we've got a reasonable response rate at a month. Unfortunately, at 3 months, the response rate drops off. And I think this has been somewhat helpful for our clinicians in trying to actually understand what happens to these patients post-discharge. And it's nice that iChomp was kind enough to accredit us for this. This is a really interesting study, actually implementation, using a distress thermometer to screen for tiered needs-based care. And so what was done here was that for our nursing colleagues took the lead in this, using a distress thermometer to triage patients' symptoms. And according to the list you can see there, physical, practical, family relationships, etc. And based on this list, based on the score here, they triaged nurse-led interventions. So there was screening, self-assessment, the nurse triaged it, and then interventions could include a multitude of things, including symptom management, medication service, care planning, etc. And this has actually been implemented quite widely. And as you can see here, it was implemented in over 1,000 medical oncology patients. It actually also did a nice randomized trial, which actually showed that there was a significantly higher quality of life at 9 months in subjects who actually used the distress thermometer. And there was also less psychological stress. There were also some measurable outcomes, including a reduction in ED visits, reduction in length of stay, and savings. So this has now been expanded to a multi-tumor support care service, reaching up to hopefully 19,000 patients, and a strong endorsement from clinicians and patients for this. And I think it nicely embeds patient voices through routine collection of symptoms and prompts and shared decision making. One other thing that we've done is actually performed a scoping review. We've identified about 115 locally validated prompts for use in Singapore. This is published by my colleague and former PhD student not too long ago. And what we found was that among this 115 locally validated prompts, musculoskeletal diseases are the most common area for local validation, and other conditions as well. We think this is important because we want to support clinicians, researchers, and health administrators in identifying which prompts can actually be used with confidence in Singapore. So we're in the process of converting this to an online platform. It's going to be hosted live on the SingHealth website for all to use in the next few months. And we'd really like to take this opportunity to invite submissions from the community of PROMs practitioners in Singapore If you have a validated PROM and you would like it to be in this repository, please do let us know and we'll certainly include it. So with that, I'd like to thank you for your attention.
Thank you so much for that presentation. Really, really interesting, particularly the case studies that you were sharing. The stress thermometer sounded really interesting, really innovative way to use PROMs in practice. So thank you. Okay, so that takes us to the end of our cluster sharing, and I'd like to say thank you to all the presenters for providing such interesting sharing and lessons. Really, really useful. So now really excited to move on to the panel discussions. So I'd like to encourage everyone again, please submit any questions you have in the Q&A box. We will try to respond to them live, if not after the dialogue. So without further ado, I will introduce our lovely panel today. So we have Dr. Albert Tai, Director for Value, Safety and Performance Division, Ministry of Health, Singapore. Professor Sandra Nolt, Director of Person-Centered Research at Monash University. Dr. Michael Vanderberg, Senior Policy Analyst at OECD. Dr. Laurie Goldsmith, a Senior Research Fellow at the Centre for Research in Health System Performance in Singapore. And Dr. Ritu Jan, President of DEBRA International and DEBRA Singapore. And she also plays a very significant role in partnering with researchers as a patient partner. Our cluster representatives will also be joining in this discussion. So the first policy question I would like to ask the panel is how can national policies incentivize the system to learn from and act on PROMs data? Perhaps Dr. Albert Tai would like to answer that question.
Yeah, thanks, Jennifer, and thanks for Chris again for inviting me the second time around. I have to say actually that the ministry does have a pivotal role in trying to move PROMs from very fragmented pieces of work to a bit more to put it into a national platform. In terms of your question, you did say how does national policy stimulate a culture of improvement in which healthcare professionals are incentivized to use PROMs? I would probably unpack this into two domains because there are two things here. One is how do we stimulate a culture of improvement in general that can use PROMs, and then the other one is actually how do we use what's the prudent use of incentives to use PROMs. I suppose there's two aspects, because in a way we do tackle that in two domains. When we launch appropriate value-based care, actually it was very much explicit that we are trying to move away from how we traditionally measure metrics for clinical outcomes and to start incorporating seriously how patient-reported outcomes should be part of that reporting metrics. And we have been taking pains in how do we almost like saying, how do we spread the gospel of PROMs across the different clusters and the different healthcare institutions, that we should tackle this the same way as we tackle our usual metrics of clinical outcomes. So that's one. We've been trying hard to set the signal for all our healthcare partners, whether not just in the public sector, but also in the private sector, that PROMs is increasingly going to be the next thing that you should start measuring seriously, especially when you start talking about how do we keep patients healthy even at the tail end of their aging in their aging twilight years. That has been, it's not just longevity, but also how to have healthy longevity is something that we want to be mindful of. So in terms of how do we incentivize this is where it's a bit tricky, because oftentimes when we talk about incentives, people automatically think about financial incentives, and we will always be cautious about not to crowd out intrinsic motivations to do good because like and I think if you look at the presentations earlier, it already shows that monetary incentives may not be the only way to do this. Even if you throw money at them, like what NHG has done with their vouchers, people may not necessarily take it on. Or in NUHS, they said about, it's more of workload. If you just reduce our workload, that's good enough incentive for us to use it. But if you add on more workload for us, then that actually is a disincentive for us to use this. So I suppose in tackling incentives, it's a bit more tricky. It's not a one-sided financial incentive. It can come in many forms. But we do want to incentivize the meaningful use of data to drive patient outcomes. I think that's the first thing that we should try to put together. It's not just for the sake of collecting data, but actually how does it impact? And that's what we want to incentivize. Whether it's change clinical outcomes is the one that we want to incentivize, not just the collection of PROMs data. I think the second one, on the national level, in terms of policy, what we can do is actually to remove national barriers or before we even talk about incentives, actually removing the barriers, remove the frictions from the adoption is actually much more helpful than just throwing money at the frictions and hoping the frictions will go away by itself. And I think the NHG example where they were talking about the invisible work, that has to be done. The barriers, these are barriers actually, the groundwork, data fragmentation, lack of standardization. These are things that will have to be done first. And incentives should actually just come at the tail end of like, okay, we've done the homework. Then, okay, let's try to put the icing on the cake and maybe the incentives will, attract people from eating the cake. So I think on the national policy level, that's what we've been doing as well. How do we create that national platform where the three clusters can come together, come up with a consensus of what PROMs tools to use, find some funding on how to buy these licenses? How do we talk to Epic on a national level to come up with a standardized federated model for Epic PROMs collection tools, and how does it flow into the clinical decision support system so that wherever you go, the PROMs tool will be able to follow the patient, whatever Epic system you are going into. On the national level, that's a way of like trying to remove the barriers even before we start incentivizing. And then I think the third one actually is somewhat related to that, is that, on closing the loop, putting in standardization of data, making sure that it's incorporated into the clinical decision support system for the clusters, for the clinicians, so that they're able to use it meaningfully. In that way, actually, you don't even have to incentivize because the clinicians themselves find it easier to use the PROMs data. They're able to have shared these conversations with the patient, and I think that's the more important thing that short of this, in a way, this is a kind of incentivizing through creating that infrastructure that makes PROMs happen. Whatever else happens at the tail end in terms of whether we need incentives or not is actually something that we can still think of. But I think the main things that we can do in terms of national levers would be how to create that environment that makes PROMs usage more pervasive. And I think that itself is an incentive, and everything else, if whether it's recognition, awards, or financial, are extra stuff that you can put into into the pie. But I think the main homework has to be done first. Yeah.
It really is a multi-pronged approach. It really is so many things to factor in, being mindful, as you say, of the workflows, removing those barriers, not just thinking about incentivization. Thank you for sharing. The next question we'd like to ask the panel is, how can investment in data infrastructure realize the full potential of PROMs? Could I ask Professor Sandra Nolt to perhaps answer this question?
Sure, thank you so much. I think most of the presenters have actually already kind of answered this question. First of all, of course, you need to ideally integrate the PROMs into an EPROM system and the electronic medical records. Otherwise, clinicians are not going to use it if they, and I've seen it before, they have to access a different system. It just falls by the wayside. They're not going to really adopt the, just looking at the data that are collected. Ideally, as Dr. Albert Tai just mentioned before, it's a system that you can actually access across organizations. So not just within the organization, but if a patient is in organization with the health services provider A and then moves into another health services provider, the PROM data get moved across, and you can actually see, okay, what did they say to the PHQ-9? How did they answer it 9 months ago or 2 years ago or just last month if they change providers again? So that would be the ideal world, really. But yeah, EPROMs as part of EMR, I think that is really one of the key topics, and the other one is really real-time analysis and reporting, so you can directly react to what patients have said. Because in the end of the day, we do have an ethical responsibility as well when we collect these data from patients, that it doesn't go into the world of you basically need to act on it, because if there are some worrying results, you need to have a clinical pathway what to do with that.
Thank you. Thank you for sharing. Dr. Vanderberg, is there anything else you'd like to add on to that question?
Yes, thank you very much. I think what's important, first of all, I really enjoyed the presentations here. I thought that I started to see a clear common thread here. And many people talked about fragmentation, and I think that's a really important element when we talk about data infrastructures. And well, as from what OECD, we've been talking a lot about data infrastructures, and frankly, I noticed that many people already start checking out once you start talking about it, because it seems to be something very abstract. So we need to agree on what exactly are we talking about here, right? And Jega, he mentioned in his presentation, is not just about technology. It is an important element, but the data infrastructure broadly is the whole system of technology, processes, standards of data collection, the storage, how you use them. And I like to think of it as sort of the plumbing behind a data-driven activity, right? It's the data was water, the infrastructure is the pipes, the storage tanks, the filters, the taps, but also the quality standards that keep the water clean. And well, why is this interesting when talk about PROMs? We so often talk about how can we motivate people to use them and to adopt it. And I think there's a lot of great work going on the ground, right, in the clinical setting. But here, this is how I look at this from an OECD perspective. Leadership on the policy level is really needed here, because there are a lot of doctors, active healthcare providers who are initiating PROMs initiative, but it's not their job to build nationwide infrastructure, not to mention international infrastructures. And I was thinking, well, let's do a thought experiment here. Imagine as a policymaker, I want to know how much money is actually spent in healthcare in my country. And I rely on all these healthcare providers and hospitals to develop a method to calculate that. Well, some of them would come up with some very smart and creative accountants who come up with great ideas. And then we have 50 different ideas to do it. And we try to figure out, some of them of the healthcare providers are maybe too busy to do that calculation. So it sounds quite absurd. And this is definitely not how it works, because there is a clear standard. There's a clear infrastructure to calculate such things, because policymakers find it super important. And now we're talking about PROMs. And I think here it's also a question of returns of investment, because we know what goes into the system. We have organized that very well in standards. We know exactly how we do that. But what's coming out of it? What does it deliver for patients? That's still often very fragmented, and it's a situation of you can call it a mess, or you can call it many flowers are blooming, right? So I think when it comes to data infrastructure, yes, there are a lot of technical questions that you can answer here, what kind of systems you can use, and we actually already saw some very good examples of that today, but it's essentially a matter of political leadership. And I think the important reason for policymakers to care about that is also because of, yes, all these great initiatives on the ground are useful for patients. They are useful in the clinical setting. But as a policymaker, if you want to know, are there certain groups in my population who are maybe worse off than others? Are there certain areas in the country, maybe, where the outcomes of care are not as good as in other parts? The only way you can answer those questions is to set up a sort of nationwide infrastructure to do things in a standardized way. And well, as you know, I'm coming from an international organization. I'm not here to make a pitch for my own work, but it's also important to do it in an international way, because this is what we often forget. As a healthcare provider, no matter what you do to improve your healthcare, to improve your services, and how well you measure it, you're always operating within the boundaries of your own system. And if we compare healthcare systems worldwide, also in the OECD, we see major differences. Why is it that in some countries, people with multiple chronic conditions have score much better on social functioning or on well-being than in other countries? These are important questions that you can only answer with looking at the bigger picture and also agreeing nationally, first nationally, but also internationally, on certain standards, certain procedures. And yeah, we're doing a lot of work on that. We have been, and I will keep this very short, but we have launched in 2025 a big international patient survey called PARIS, where we measure outcomes and experiences of patients across countries in the OECD. Still open also for non-OECD members because we go into the second cycle now. And we have been also trying to compare outcomes on condition level, for example, for breast cancer and hip and knee replacement. And there we see that, yeah, there are a lot of systems out there, but everybody is doing it slightly differently, right? So having this sort of agreement on how we do is important. So yeah, I would conclude in what a good infrastructure would look like, I think, is agreed PROMs tools that are tested, that are valid, that we agree on, agreed platforms and methods for data collection, all the technology, agreed procedures, so the frequency, the data flows, how do we collect them, when do we collect them, and also quality standards for data collection. And I think I will stop here for now.
Thank you. Thank you for sharing. And really interesting that you took that sort of international perspective as well. We've talked a lot about institutional level implementation, but actually PROMs have value at that international level as well. And maybe that's another way to incentivize stakeholders to use PROMs as well. Okay, thank you. Next question. How may the systematic involvement of patients in the design and development of PROMs be best achieved? I'd like to ask Dr. Ritu Jan to answer that question.
Thank you, Jenny. First of all, I'm really glad that we aren't talking about should patients be engaged, but how should they be engaged systematically. So I am a rare mom. My daughter has a rare disorder and president of DEBRA International, which is, I'll just put it in the chat because DEBRA is Dystrophic Epidermolysis Bullosa Research Association. Started with that, but now it's a global patient alliance for people living with the rare genetic disorder epidermolysis bullosa. And it's a global alliance with about 50 national chapters. So I sit at the intersection where most PROMs conversation, at the intersection that is missed by most PROMs conversations, because rare disease families teach us a sharp test case. If a PROM works for someone with a painful, and EB is known as the most painful condition you've never heard of, then if it can work for such a poorly understood and painful disorder like EB, it'll work for almost anyone. But how do we get there? That's your question. So I have some points that I'd like to share. First, based on the policy brief, involve patients across the whole PROMs life cycle, not just at data collection stages. Because once you make patients stakeholders with skin in the game, they get involved. And some of the challenges that have been alluded to by some of the speakers, like they're not incentivized through throwing money at them or persuasion. So maybe the engagement needs to come much ahead in the life cycle. To give you an analogy, when you're designing roads, you don't just consult city planners and engineers, but possibly engage with taxi drivers who use the roads. The brief itself flags this, and OECD data shows that 21% of PROMs programs systematically engage patients really at a later stage, and at the stages of consultation or being informed, but not really at the design or decision-making stage. That's the low end of the participation spectrum, when what actually changes outcomes is when patients are treated as co-designers with real decision-making stake. Of course, there are frameworks like the classic IAP2 spectrum of public participation, which goes from inform, consult, involve, collaborate, and empower. As it's a useful framework given most PROMs programs sit at the low end, and we need to move rightward. So a suggestion is patients need a seat at the table when target outcomes are being identified, the brief step 2, when instruments are being tested for acceptability, step 4, and where relevance is reviewed, step 5. This will ensure that the items reflect lived experience rather than the assumed burden. This is where concepts like co-design workshops, patient advisory panels, and qualitative concept elicitation interviews, which are standard in FDA-endorsed PROMs development, are relevant. The other point I'd like to make is on equity and representation. This is a gap flagged in the brief as well as a stage 3 consideration. The need to address this is critical because rare diseases, pediatric, low health literacy, migrant, elderly patients are structurally excluded from most PPI exercises because engagement defaults to whoever is most articulate, most available, most similar to researchers designing the process. Case in point. From my rare disease perspective, a generic PROM often simply doesn't capture what matters to patients. From the EB perspective, understanding pain, wound care burden, social stigma, these are issues that an EQ5D, for example, wasn't built to capture. So a useful illustration of patient involvement is possibly the QOL-EB, Quality of Life in EB questionnaire. The items for this questionnaire were derived from qualitative interviews and focus groups with EB patients themselves, rather than adapted top-down from a generic dermatology tool like DLQI, which EB studies also use, but which wasn't built around EB-specific burdens like wound care time, which in the severe forms averagely take about 3 hours a day. This was not factored in the standard questionnaires. So with the QOL-EB, wound care time, mobility from palmoplantar blistering or scarring and contracture, these impacts are incorporated and measured. The tool has a very high content validity because patients' own language and priority domains, such as pain, age, daily wound care burden, mobility, etc., and social participation, these shaped which items were retained. I have other examples, but I'll briefly allude to the iScore EBP, which is the patient-reported companion to the clinician-scored iScore EB. This was built through another international collaborative input to capture patient-related outcomes alongside clinical signs that illustrate mostly patient clinician measures. So it wasn't a clinician-driven instrument retrofitted with a patient version, but developed specifically for that. I have some other examples like the COS-EB, which I won't go into, which is a core outcome set for EB, which we are currently developing to define core outcomes and core measures through consensus processes for clinical trials to enable more successful and impactful clinical trials. But basically, the systematic involvement has to mean deliberately reaching out to underrepresented groups, not convenience sampling. And it is worth exploring how Singapore's tripartite cluster system plans to reach, and I turn the question to all of you, how do you plan to reach underserved groups specifically? What's the plan to reach patients who aren't already plugged into hospital advisory structures? The other point I would like to make, and I'm happy to conclude soon, many of the speakers, including Lizzie and Jika, have already alluded to earlier, but we have to move towards structural mechanisms, not one-off consultations, because sustainable PPI needs institutional infrastructure, such as standing patient advisory committees, compensated patient partners, which is something I've seen huge hesitation in at the institutional level in Singapore, and training both for patients so they can understand the purpose of PROMs and staff who should have the skills to facilitate engagement in PROMs. I appreciate that this is mentioned in the brief, that skilled facilitation, etc., are to be considered. And this links to the barrier the brief notes at the organizational level that routine PPI is often not prioritized. So my final point that Dr. Albert Tai also referred to in closing the loop, another way of closing the loop is by showing patients their input changed something. This is really meaningful in engaging patients and keeping them engaged, not one-off. Because a recurring failure mode in PPI literature, and also implicit in the brief's warning, is that consultation fatigue. Patients give input, but never see it reflected in the final tool of it or its use. So effective programs should report back to patient contributors how their feedback changed or shaped PROM selection, PROMs design, and revalidate its relevance with patient input built into the review cycle. I'll pause here, but happy to take questions or clarify later.
Thank you, Dr. Ritu. Thank you for reminding us all as well how important it is to engage with patients early and throughout this whole sort of PROMs journey. It's really valuable. Dr. Laurie Goldsmith, I wonder if you have any comments or reflections you'd like to add on.
Yes, thanks, Jenny. So first of all, I want to heartily endorse everything that Ritu said. And just like you, Jenny, I think one of the most important things is to remember that we need to involve patients in the public early and often. It's not a one-off activity. If we don't involve them early, it's the same thing as not involving a methodologist like a biostatistician in a clinical trial. Why would we expect that we can substitute for the patient voice, for the lived experience by researchers and clinicians who don't necessarily have that lived experience? I also want to pick up on one of the things that Nick said in highlighting some of the findings in the policy brief in the first presentation. He mentioned that measures were misaligned with patients' values. If we're not involving the patient voice and patients from the start, why would we expect that we would be able to align the measures with the patient voice? Every time I've involved patients and the public in my research as partners in my research or doing PPI, they have added to the work, they have improved the work, they have enhanced our understanding of the problem. So the same thing is going to happen in PROMs. And then the last thing that I want to say, because I know that there's another question that we want to talk about, is I also want to pick up on the invisible barriers that Dr. Albert Tai talked about when he was giving the administrative perspective. We assume that patients are not valuable contributors far too often. We forget that all of us are patients. Patients are CEOs, patients are researchers, patients are physicians, patients represent all aspects of our community. And even the people that we might expect are not well educated, they are well educated about the lived experience of the condition, and they can add very, very valuable information. I think thinking about patient and public involvement across healthcare delivery and across research is an important normalizing factor of centering the patient voice. And I'll stop there. Thank you.
Thank you, Laurie. Thank you so much. Okay, I think just going by time, we've probably got time for one more question. So I would like to ask, to what extent should PROMs be used for quality assurance purposes? And this might be a good question to direct at our cluster representatives. Maybe I'll go to Professor Fumbo first.
Sure, thank you. I think it's important that prompts can be used for quality assurance, certainly at the individual patient level, also at an institutional and a policy level. So just some quick examples to illustrate this. I think at an individual patient level, prompts can be useful for screening for undetected conditions. As an internal medicine physician and rheumatologist, some studies have shown that 30% of patients in an internal medicine clinic have got some degree of mild depression. And in my own specialty, that doubles, which is quite frightening, right? And so prompts can actually help us to pick that up for quality assurance purposes. Also, in terms of treatment monitoring, certain diseases, for example, irritable bowel syndrome, very, very, very useful. For prompts are very useful there. At a policy level, prompts definitely are important for comparative performance assessment and for clinical audit. So one specific example is NESSCRIP, which some of us may be familiar with. It's a international surgical database comparing outcomes for various procedures, and prompts are included in NESSCRIP, and I think a very important factor there. And certainly at a system level, I think for looking at quality assurance and value-based care, prompts are very important in VBC, and I think we all know how that works out. So I'll just pause here and perhaps invite my fellow cluster colleagues to give their comments. Thank you.
Thank you. Jager, Huang, would you like to add anything?
Yes, I'll just share a couple of thoughts. So I think with quality assurance, it definitely depends how we're defining quality assurance. But from the perspective of appropriate and value-based care, so as one of the things that we mentioned at the beginning, I think we really see prompts as a way to democratize how value and quality is defined for our patients. So for example, a patient that has a total knee replacement, our current clinical outcomes that we're looking at are things like, was there any inpatient mortality? Was there ICU transfer? Was there any post-op complications? Was there readmission within 30, 90 days? These are great outcomes to track. But at the same time, is the patient still in some pain a few months after the operation? Can they now do things that they couldn't do before? Like, can they climb the stairs better? Can they do their gardening? Can they chase after their grandkids? Things that matter to the patient and is the reason why they wanted the elective in the first place. These things should be measured. And I think we definitely see prompts as a way to help bring in another angle of looking at the patient. But that said, there are still obviously limitations with prompts. We probably need to handle them on a case-by-case basis. Different populations probably need different MCIDs, different tools. And the workflows are also going to be different. So I think to answer the question, we definitely think to a large extent, prompts will be useful for this, but with a degree of caution as well.
Thank you.
Yeah, thanks both for sharing your insights. So I think my thoughts kind of really echo what Jagger mentioned. It really depends on the purpose, right? So in the context of like quality improvement or like care delivery, I think prompts should be central to how we measure quality and how we engage our patients because they really tell us whether we are delivering outcomes that matter to them. And it ensures that, our patients' perspectives are also taken into consideration when we are forming care decisions. But if, say, we are moving from learning to assigning accountability, so that could be in the form of like benchmarking incentives or performance management, I think that's where we need to be a little bit more cautious in how we then interpret the prompts data. And we will need increasing levels of confidence in that data. So that means ensuring things like you have adequate response rates. It needs to be representative of your patient cohort. There needs to be evidence that the outcomes that are measured are meaningfully influenced by the care that's being delivered. So these are all considerations that we have to account for. Yeah, so if I could summarize my thoughts are, I think prompts should have a major role in quality assurance, but they should also be used to complement other indicators of quality because oftentimes I think, be it prompts or other quality indicators, they each tell a side of the story, and we need all of them in order to have the full picture.
Thank you. Thank you for sharing. Conscious of time, I would love to continue this question and answer session, but unfortunately, I don't think we can answer any more questions. We will endeavour to address any points that haven't been covered after the session, so do bear with us and feel free to reach out. But I'd like to extend my thanks to the panel today. Really fantastic discussion. And I will hand over to Prof. Valderes, who will just make some concluding remarks and sum up the session for us. Thank you.
Thank you so much, Jenny. And most catastrophically, I think for some reason, I've lost the ability to share my screen, or my face, which I have been doing throughout all the dialogue. Can you confirm you can hear me?
Yes.
Okay, thank you. Really sorry, not sure what's happening. I think, I was sitting here itching to jump in at so many issues that were mentioned by the very distinguished panelists, and I really want to thank all of them and their institutions, because all of them are being instrumental in making huge progress with the use of PROMs for supporting decision making in health systems at various levels. So I'm sure whatever I summarize, I will probably not make justice to what was said, but so let's agree it's my summary. And so the issues that I picked up on, we had Ms. Huang Lezi talking about governance, how critical this is, how crucial it is to have an iterative co-development of PROMs and on the PROMs, of the PROMs pathway and methods and systems for data collection and feedback, and also how crucial it is to have effective patient engagement through trust. And I think all these three things from the cluster from NHG, I think were resonated well with the other clusters. Dr. Jiga Pratibha emphasized the notion of a whole system approach, and also highlighted some of the tensions between addressing the fragmentation of the efforts, which is the traditional let a thousand flowers bloom, but then also, how you balance the more coordinated, harmonized efforts with clinical ownership, which I think is quite crucial for, in many instances, moving this forward. We need clinical champions, and that ownership is essential. And there was also a reflection about how, during this process, how to maintain clinical standards. Professor Julian Thumbo, reporting on Sing Health, made reference to existing frameworks and the utility of them. So we're not operating in a vacuum. We do have guidance, and we also have solutions, and perhaps solutions that may have been so far, perhaps to a large degree, we may have not paid enough attention to, and that would be, for instance, CAT, computerized adaptive testing. And also this, the very situation in which we find ourselves, opens up the way for experimentation. And that was also something that was very fresh to hear. And then we heard from the panelists in relation to the prudent use of incentives, in the need to integrate the data. The PROMs data with clinical data, how policy and leadership is also one of the things that are probably most needed, and how patients need to be engaged early, also at the crucial step of the decision-making process to the final one. But also that, the feedback comes from people from all walks of life. So we shouldn't make assumptions about what sort of feedback patients would be able, more feedback, engagement, people would be able to be involved in. So I think it was all very varied set of contributions. I'm aware that we are already exceeded the time, so I would simply just to say, we have links for you to share. For you to share in relation to other activities, but also about this of CRIHSP, of the Center for Research in Health System Performance. We will answer all your questions in delayed format, and they will be put also in the when we release the recording. And I would like to hand over back to Jenny for closing the meeting.
Sure. So just flashed up on the screen here, we are planning on running a workshop on patient-reported outcome measures later in the year. If it's something you think you might be interested in, please click on the QR code and express your interest. So just wrap up by saying a huge thank you to everyone that participated today and all the participants online. Thank you for staying with us right to the end. I hope you found it interesting. And if you have any more questions that you weren't able to ask in the chat, or you want to follow up with anyone in the team, then please reach out. We're very happy to continue this discussion offline. Thank you, everyone.